appreciated. It's my pleasure to introduce Dr. Deborah Mason, who is a consultant neurologist at Christchurch Hospital and currently leads the MS research group, whose principal focus is clinical research into multiple sclerosis. Deborah is also a clinical senior lecturer with the Department of Medicine, University of Otago in Christchurch, and a lead researcher with NZBRI. In the latter role, in 2006, the MS Research Group completed a nationwide study into the prevalence of MS, identifying 3,000 people with MS in New Zealand. This study led to an international collaboration involving over 1,500 New Zealand MS patients who contributed genetic samples, resulting in the identification of 29 novel genes in MS. The group's current research projects include a nationwide incidence study of MS and vitamin D intervention trial, and also some other research interests, including finding imaging biomarkers for MS pathology and prognosis. But today, I'm delighted that Dr. Mason is going to talk about her recent sabbatical and what she's learned from her overseas colleagues about what the future of MS services might look like in Aotearoa, New Zealand. Please welcome Dr. Mason.
Gosh, thank you very much, and thank you everybody for coming. And isn't it lovely that we have such a wonderful facility to gather in today, and a great deal of appreciation to those who have made this Braintree, which is so special, possible. So today, I know there's probably some of you come with different expectations in terms of what you'd like to know, and today I've been asked largely to talk about my sabbatical. We won't talk a lot about research, or we will touch on some things from overseas, but we have talked about the fact that later in the year we may do another talk and perhaps look at a lot more. Somebody today was asking me about T cells, and a lot of people have been asking about the Epstein-Barr virus and things like that. So hopefully we'll get the opportunity to have another talk later in the year if they ask me back after this one. All right. So I think that before I went away on sabbatical, we're kind of privileged as doctors in that there is an opportunity to do a 3-month sabbatical. Now that's meant to be every 7 years. It took me 20 years to order one out of the DHB, but finally it happened, and it's quite a privilege to be able to go away and to have time away from your day-to-day work to kind of explore what other groups do. And so I reflected for a while on what my goals for this sort of time overseas were, because I know some of my patients think that it was just a glorified holiday, and there was definitely some holiday involved, but I also did some really interesting things with other groups. I had done my MS fellowship in 2001, and the BC, just for you who think I'm that old, was actually before we had sort of our contemporary treatments. And it's very interesting to reflect back over 20 years of really what's changed. When I worked in Canada during my fellowship, we had beta-ferron, was just becoming a drug that we use. 20 years later, we've now got 20 medicines for MS, still not there completely, but the landscape has changed enormously. The other thing that we've learned a lot about, and something I wanted to look at, which we won't talk about today, is that when we saw somebody with optic neuritis or transverse myelitis, spinal, everything was MS in those days. We didn't really have high-powered scanners. They weren't that, there wasn't the opportunity to get everybody scanned. But as time has gone on, of course, we've now recognised that there are a lot of MS mimics. And some of those have different prognoses, and also they have different treatment modalities. And so we've been able to identify different types of immune conditions. And some of those are like what we call MOGAD, which is a myelin-associated disorder, and neuromyelitis optica. And those, interestingly, some of those things actually do badly if they get MS drugs, so it's important to recognise them. The other thing that you'll see when I was at one of the clinics is that we've also recognised a lot of immune-related disorders that cause other conditions that are not like MS. And obviously I do a lot of work with MS, but I'm also a neuroinflammatory neurologist, and so I do a lot of work around neuroinflammatory conditions in general, and encephalitis particularly, which often present with epilepsy. So I wanted to explore some of those because they are rare conditions, and we get to see one or two, and but when you go away overseas, you get to see clinics which have a whole lot of these patients, and I get to see the spectrum of these disorders. As I said, there's been a huge change in the landscape, and I was really interested to see what other groups, what drugs they're using. As we always think, does everybody have better drugs than we do? And then how they use those from sort of a logistics point of view. What kind of treatment algorithms do they use? Who do they put on what and why? And also just the logistics, you know, of how we manage these medications in our communities, as well as are we in New Zealand, or certainly in our group, following best practice. So that was kind of my goals for going away. So I started my travels, well, I actually started my travels with a week in New York, which was kind of cool, except I got COVID. I had to flight over, but anyway. And then I went to the Mayo Clinic. Now this is an extraordinary place. It's in Rochester, Minnesota. If you've ever been to Rochester, Minnesota, there ain't a lot there. There's a lot of nature, but there is this amazing facility, which is the Mayo Clinic. And this guy here is William, and this is Sister Alphys. And William Mayo was a GP in Rochester. And in 1883, there was a devastating tornado. And he was sort of the triage person, the only person on the ground, largely. They were quite cut off, and there was a huge number of casualties and deaths, not unlike our experience with the earthquake. And he linked up with the Sisters of St. Francis and basically created this sort of ability to look after these people. And after it was over, Sister Alphys then came to him. These were not medically trained nuns, and came to him and said, listen, we will fund a hospital for people, and if you would support us, then, and support my nuns to learn about medical stuff, we will support you. And that philosophy runs strongly through Mayo. It's a strong Catholic philosophy, but on the other side, it's all about giving. These were incredibly humble people, and his legacy was carried on by William and Charles, who were his sons, who were also surgeons. And they built, over their lifetime, a phenomenal facility, which is one of the most sort of well-endowed philanthropic centres that you will see. When you walk in there, the whole sense of it is about the patient. The whole thing isn't about money or gain, and it's a really, really lovely place to work. I said to people, you know, you turn up at the front door and it's like you've come to a 5-star hotel. Everybody who works there is so proud of working at Mayo. We could learn a lot from this. The orderlies, yes, where do you want to go, ma'am, and take you, and it's just extraordinary, really lovely. So they've built an amazing legacy, and part of that was just being incredibly open-minded. They were willing to explore, including getting all the nurses out of the, teaching the sisters to be nurses. They were some of the first people to take on board some of the new anaesthetic practices. They travelled widely, they brought people in with new ideas. They had anaesthetics before lots of other groups. They also were very, the first to use hygiene therapies and things like that in surgery, and so a wonderful legacy. This was just to prove to you that I wasn't completely on holiday. This was the little box that they gave me, which was lovely. Now, when I first got there, I kind of, Mayo Clinic don't take observers anymore since COVID, and I was lucky enough to have a lot of contact with Sean Pittock, who is the head of the neuroimmunology clinic at Mayo Clinic, and he, through getting me through the lab, allowed me to work there for 2 weeks. And so what this is that I spent the mornings in the lab with getting a crash course in rodent biochemistry. But these are rodent brains, and basically they've got cerebellum and they've got some sort of cerebral cortex and all the bits that you need. And what they do is, and what they're really known for, is being able to develop these little markers here that attach onto different parts of the brain and give us an idea about the different immune conditions. Now, this is my scribble, and the reason that I was interested in this is not so much the lab-based stuff, but each of these conditions come with neurological syndromes. And they're rare syndromes, and so it's important to be able to recognise them. And so I spent my mornings going through the slides, but also looking at, this GAD65 comes when a person comes with cerebellar symptoms and stiff persons. And then in the afternoons, I was able to attend the clinics and see some of these people. So that was a wonderful experience, and I was there for 2 weeks, and people were incredibly generous. I went to another number of clinical things. I went to St Mary's Hospital, which was run by the nuns, and I also did neuro-ophthalmology clinics and a whole lot of other clinics. So next stop was London, and anybody's been to London, it always rains. I had 6 weeks there, and it was like this almost every day. It was the most exquisite summer, sort of spring summer that we had, and it was just absolutely lovely. Now, where I was based was, actually I've got the wrong I've got the older presentation, but that's fine. I was at a place called Queen Square. Now, this is the National Neurology and Neurosurgical Hospital in London, and it catches from all over England, but largely from its catchment around London. It's based at Queen Square, which is why it's called that, and it is everything neurological, really, and neurosurgical. So it doesn't have general hospitals. What it does have is lots and lots of clinics that are associated with different neurological things. So there is the dementia clinics, cognitive clinics, movement disorders clinics, and all of those. And I was based largely in the MS clinic. So I thought I'd give you a bit of an idea of what this clinic looks like. So they have 14 consultants, which is 5 full-time equivalents of neurologists. They have 10 nurses. And again, this ratio is something that we don't have in New Zealand, and the nurses create and do an awful lot of fantastic work. They have physio and OT support that is present at all of the clinics, and so patients can see the physio and the OT if they want to. They have a dedicated walking and spasticity clinic where they might do things like Botox, Fampridine. Some of you may be on Fampridine, and they assess people for Fampridine. They also look at orthotics and all of those sorts of things. So, and they have a neurologist, and she works also with a rehabilitation physician, and they create programs for people that then the exercise physiologists and others will then follow up on. Because people often come from quite a big distance, and so they end up getting little programs like at Mayo Clinic that they can take away. Now, they have a pregnancy clinic, again, a neurologist and a CNA, clinical nurse specialist run that clinic. I did one of the obstetric clinics over at the obstetric hospital at University College. They have obstetricians, neurologists, and again, nurses. So everybody who is pregnant would be seen there and given advice if they need it. They have a urology clinic, so people with urological problems that are related to their MS are seen in that clinic. So a really comprehensive group. They have a pharmacist, and we'll talk a little bit more about why the pharmacist is so important to all of this, and ophthalmologist, and they do a weekly Teams meeting. Now, I thought it would be interesting to you because, one of the things we often say is, people overseas, there's so much more opportunity with medications and things like that. One of the things that I took away from my time, particularly in England, but even to a certain extent in America, was that we have, I think, the best system in the world. So when Pharmac licensed medications in New Zealand, they basically said, these old injectables, they're very modest. If you're going to use a treatment, you need to use a treatment that's higher efficacy. And so what they did was that they funded all of the drugs that are available. And they did it in a way that allows myself and other neurologists to use them where we think they are most appropriate for patients and to switch between the drugs without problems. That is not the case overseas. So what you end up with is here is that you can see they have 2,500 patients in their clinic. We have in Canterbury about 450 patients currently on treatment. They still have quite a lot of people on injectable treatments, a lot of people on orals, and they do have cladribine, which we don't have here, which is the only drug that we really don't have. We have all of these. And interestingly, they use a lot of ocrelizumab. You can see that a lot of people are on ocrelizumab, but not very many on natalizumab. And that again is to do with the funding. So when I said that they need a pharmacist, the reason they need a pharmacist is it is incredibly complicated as to which patients are eligible for which drugs. And there's a lot of discussion that goes around that. And to get natalizumab, you have to have a highly active disease and actually have had to have failed ocrelizumab. So a lot of these rules are regulatory rules, they're about funding, and they don't make any clinical sense. So I think we can be very proud of Pharmac that they funded drugs and then they left the clinicians to make the decisions with the patients as to what's best for people. I will talk a little bit about this. This is the injectable ocrelizumab, and so these are all their infusion-based treatments. The other thing that's really interesting is that if you live miles out of London, you have to come to Queen Square for your infusions. So you might do 2 hours on the tube every 4 weeks, because they still do 4 weekly infusions, to get your drug. And if you need blood tests beforehand, you have to come. They don't do them through the GP services like we do here. And so I'm very proud in New Zealand of our Burwood, West Coast, Ashburton, Timaru. We try and make these things appropriate to where people need their infusions. And you can imagine negotiating once every 4 weeks the sort of rail system, particularly currently because there ain't any, in England. And so again, this is an issue with the kind of very centralised service. And then in the more peripheral areas, patients will often end up with private neurologists and hence be just on injectable treatments because there isn't the opportunity to put them on the higher efficacy treatments. So from that, I decided that we really do very well. The NICE guidelines, which are the English guidelines, are in fact very complicated. But there are a few things that we picked up. The mounting sort of observational data with cladribine, and we are pushing at the moment for Pharmac to consider cladribine, particularly for people that might be on Tecfidera or other drugs where if you want to go overseas, you get 2 years of treatment for 5 days and then it's over. Although some of the data shows that people do end up relapsing again at the end of 2 years, and so it's not probably quite as powerful a treatment as our ocrelizumabs and our natalizumabs, but suitable for a number of people. And where we think that we might use it quite a bit is in people that have been on treatment for a long time, have declared themselves as very stable, where we can use an exit strategy for this. Because nowadays, previously, and many of you will remember these times, you had to actually have significant disability or relapses to get on treatment.
Now, of course, we put people on treatments very early, and so not everybody that's on treatment will have needed those high efficacy medications. And so time gives us an opportunity to see, can we change treatments, can we scale down with some of the treatments, and what we're doing. And a lot of people around the world are currently talking about that at the moment. So there is a strong move towards injectable treatments overseas, and some of this is just related to how far away you live. So if you do have to come to London, it's much easier to, rather than come every 6 months for your ocrelizumab, to just do your injections every week. We haven't got Roche on board with this. It's not a Roche product, but natalizumab, certainly we think that we will have subcut natalizumab possibly by the end of the year. So what are the challenges that people are facing? Well, one of the things I learned is that we're all kind of in the same boat at the moment, and everybody's talking across the world about the sorts of things going forward that we're going to need to address. One of those is better information about the long-term effects of our high-potency medications, particularly with respect to safety data, but also pregnancy data and data about people who get malignancies for other reasons, people as they age. What are we going to do with these drugs in the long term? And there's a lot of discussion around that. Who's heard of PIRA? All right, so PIRA is something that is now kind of cutting edge in neurology. I suspect that people that have been in the game a long time, like me, have always been aware of it, but the Americans have put a name on it. So once we developed high efficacy treatments, we are seeing patients who have had no relapses, no clinical data, sort of problems, and their MRIs are stable. But they come back to see us and they are still progressing. And this is called progression independent of relapse activity. And it's only really become very apparent to us as we've had these high efficacy treatments. Now the problem is that we can't predict who is going to fall into that category and who isn't. And we still don't understand the mechanism underneath that, but I think that is where the research is going. Can we identify PIRA, which probably starts early in the disease and may be specific to certain people? And if so, are there treatment strategies that are better for it than other strategies? And I think at the next conference that I go to for MS, which is in Copenhagen in September, that will feature very highly in many of the papers as to, now that we have good drugs that keep people well, how are we going to do, what are we going to do about those patients who are still progressing, and how do we monitor that, and what do we do about it? Now, the other thing which I wanted to have a look at is where we're at with autologous stem cell transplants. And interestingly, the Mayo Clinic don't do them. So, in America, you really don't see stem cell transplants. England have done a number, and they at Queen Square, where I was, are doing a trial. And what they're doing is that they are taking patients, and the big question for people is bone marrow transplant better than high efficacy treatments? And so they're taking patients who are naive of treatment, and they are randomizing them into bone marrow transplant or ocrelizumab to see what the outcome is. They're really finding it difficult to recruit because so many patients who are on ocrelizumab are doing really well and don't want to go on the transplant list. It's a big procedure, although obviously afterwards you get that period of time of freedom from any treatments and having to see neurologists and all of that. The question we still don't know is whether bone marrow transplant changes the biology of multiple sclerosis in a way that it advantages people in the long term. And that is the big question. Does it change your immune repertoire, if you like, to then improve or to reduce the risk of MS? We know it's not curative. We know that there are a number of patients that at 10 years post-transplant will start to reactivate. You see new lesions on the MRI, you see new relapses, clinical relapses. So we know it's not curative, but what is it about it that's special, and how is it different from infusions such as ocrelizumab that we also can really shut the disease down? And I think that's, this trial will be, it's called the STAR trial, and I think it'll be a very interesting trial, and it will help to inform us going forward. And one of the hopes is that it might be the group with PIRA that it might make a difference to. We don't know that for sure. So, what are the challenges that I see in New Zealand? Well, having come back, I think that one of the issues is that our MS clinics increasingly, because of the way that our funding is, have started to focus more and more on patients who are on treatments. Now, as life goes on, most patients will be on treatments, but I think there are many of you who have not been able to see neurologists and therefore aren't getting patient management for symptomatic treatments and things like that. And I think you can see with that London group, walking clinic, spasticity clinic, all of these sorts of things, urology clinic, those sorts of things that really make a difference to people's lives. We do our best, but some of those clinics can be really helpful. And one of my big worries is that as we get injectable treatments and the special authorities change, at the moment, having to have a special authority every year means that we need to see you, and we like that, and we catch up on all sorts of things. Now, if that special authority was dropped, and I've had a lot of experience with this with epilepsy, patients just don't get seen anymore. They end up with their GPs, some of whom are really good, but they don't get the kind of level of care and the more comprehensive care input from the nurses. And that, I think, is a risk that we're going to face, particularly with the injectable treatments. And I think we have less of these specialist clinics, such as the urology clinic and the walking clinics and things like that. But Te Whatu Ora tells us that there's lots of opportunities, and we hope that might be the case. I think that one thing that Te Whatu Ora has done is they have focused on equity across the country, and that has rallied a number of us who work in the MS space in Wellington, Auckland and other places to create paradigms and some of the algorithms that I told you that I was looking at overseas that we will place across the country to try and make sure that everybody gets the same opportunities and that we work together. We're a very small group, we all know each other, and so what we are doing at the moment is that we are trying to create sort of algorithms where we treat people and use similar kinds of ways. Now, in some places that will mean that some people have to up their game, and in places like ours, Wellington, you know, we're trying to benchmark against how we think things should be done. Education is something that we're focusing on a lot. And one of the things that I think is coming out with a lot more research is the apps that people have, lifestyle well-being. I was just talking before about the fact that exercise is now thought to be the second most important disease-modifying drug. And I learned quite a lot of things about phone apps, and one of the ones that the nurses in England taught me, which you all better watch out because I'm going to do it, is grab your cell phone and look at your last step count for the last month when you tell me that you have been going to the gym and you've been going out every day, and I can see whether that's true or not. And they actually record when you come in what your step count has been over the last month. So watch this space, everyone. No standing by your bed doing this the night before you come in. I think that this sort of advocacy and things will allow us to use this orange stuff, which is brain health initiatives, and so that we can work across the country for advocacy and saying, well, look, this is the way it should be done, and this is auditing that. And finally, also looking at trying to defragmentize the services for disability, occupational and housing. I think housing for people with disability is a travesty at the moment for young people, and those are the sorts of things that we really need to start looking at. All right. I did do some things outside of work. So in New York, I went to a lot of shows, which was really good. This is a guy called Ryan. I don't know whether any of you know him. He's quite a famous actor in England. It's quite an interesting play, this. It was about a Venetian doctor who was the first one. So they had a maternity unit in Vienna, and in one unit, it was all the doctors that did the deliveries, and in the other unit, it was midwives. The death from puerperal fever in the doctors was at like 80%. It was huge. In the midwives, not so much, much less. And he became an advocate of trying to work out why this was. He discovered that it was because the nurses, one, didn't go from the autopsy unit where they were looking at straight to the board to do the delivery with no change in gear, and the nurses washed their hands and did stuff with lime, and he became absolutely fixated that this was true, and nobody in the world at the time would believe him. And sadly, he got completely marginalised and in fact went mad and died of septicemia himself in a mental institute.
God.
And this was written and played by this guy here. Now the really interesting thing about this was that he was an anti-vaxxer. Go figure. And then this was a wonderful dinner that I was able to attend. This person here, Lionel Ginsberg, one of the most fantastic neurologists, and who I worked with when I was in London in 1999, my mentor, and all of the guys that I worked with back in London, and most of them were guys. There were very few women. It was me and two others. But it was a lovely dinner and a farewell for him. So that was sort of my experiences across the board. I guess in general, I thought that people do things slightly differently, but I think we could be quite proud of how we're doing. There are still a few things that we haven't got, but actually I came back feeling that our services do a pretty good job, actually. Absolutely.
We have a microphone here for questions. I see a hand up already.
Straight in there. Thank you, Deborah. That was a brilliant summary of your trip. I wondered if you came across how organisations like MSPC or MS New Zealand work with the professional medical side of things.
Not a lot, no. Most of the nurses that, and again, this is this sort of centralisation of things, is that the largest group are within the hospital systems. And I didn't actually ever get out very much into the communities. It would have been nice actually to sort of have, because I know that MS UK, for example, a very strong group there, but and I didn't see a lot of referral either by people. I think the nurses probably do get quite a lot of referral, but I kind of gained the understanding that they didn't become involved in, as our groups are, with sort of the ongoing. It was more a support kind of group, and most of the information and things was given, in fact, by the nurses at the hospital. That's a very good question, and I think it would have been nice to have a bit more perspective of that. I didn't see anything in Rochester like that. Of course, Rochester draws from all over the US and all over the world. They're a one-stop shop, extraordinary. People turn up and everything is done. There are hundreds of hotels in Rochester because you turn up in Rochester and you're there for a week and everything is pre-planned. So on Monday morning you get your MRI scan, then you get your nerve conduction studies. The following afternoon you get your CSF examination done, and they have these amazing sort of health workers who put all the bits together, get all the patients done at all these different times and things. And so when the patient turns up, they have everything done known to mankind, and then they see the appropriate people, a diagnosis is made, and then a treatment plan is put in place that the patient then takes back to their home base. And the disadvantages of it is it's hugely expensive because every test that's been done already is repeated, and the big advantage of it is by gathering that huge amount of information, they can do the research of, because they've got 1,000 samples of this, you know, and things like that. And so there's real pluses and minuses with respect to that, but I really like the idea that the patients come, they get a really robust investigations, all done at once, so you're not waiting 8 weeks for this and 6 weeks for that, and then see Debbie in 6 months' time. And then they sit down with you, and then you get a very clear idea of what's wrong with you, or what they think, and then ideas about how your home physicians might manage it.
When you were in the States, did you come across these PONS devices?
The walking ones?
Yeah, the portable neuro
The leg ones?
things. Yeah.
So, not in the States, but in fact I came across them in London, and I should have actually put that in. I've got a little video of them, and so they, in the walking, I did a day in the walking clinic, and what they do is, I just wonder if I've got, just trying to think, no, I don't think I have it on there, so what they do is that they get patients walking up and down, and then they put the device on. And what we're talking about here is, as you know, for a lot of people, foot drop of one leg is a real issue, and it sort of exposes people to falls risk and things like that. And for a while, our physios did have this system, but it was we used to put the wires up and stick them in their pants. But basically, it's an electrical device which allows us to stimulate the nerve here, and as the person walks, it lifts the foot. And it's a smart device because we put it in your shoe, and when you do a heel strike, it triggers, and you can feel it goes bzzzt, and it lifts the foot up. And I've got the brand name of them, and the ones that they use. And the physios hook them up, and then the patients walk with them and look and see whether it helps when they're walking. There are some in the United States, they're like $11,000. They're highly programmable.
They've been improved now, though.
They have, yeah, and you can get different programs, so they change with walking speed. You can use them for running and things like that, so you don't trip. And yeah, no, so that is one thing that I did bring back, and I've got the photos of them in terms of what they do and the brand names, which I think we could import actually.
Yeah.
You can actually hire them here
That's right.
through
Yeah.
the physios.
Physios,
So
that's right.
yeah, I've used them.
Yeah.
but they take a bit to get used to. They definitely do. Yeah.
And I think that's where the ones that are quite nice with the heel strike in them,
Yeah.
because it takes away that having to sort of fiddle with them. And once they get them programmed properly, then they just work with your natural gait.
Yeah. No, that's very cleverly done.
Yeah.
So, yeah. Physio, on the go physio, the
Yeah.
neurophysios
The
have them.
neurophysios there do
Yeah,
them,
they do. Mm.
Yes.
Does the subcut Tysabri,
Yeah.
does it have the same PML risk as the infusion?
It's certainly no worse that we know of. The problems are that we don't have the big data on it. So,
Sorry, what was the question?
oh, sorry. Sorry, what was your name?
Mandy.
Mandy was asking whether subcut natalizumab, rather than the infusions, had the same risk of PML. Now, interestingly, PML risk, I think, it's something that we really focus on. As you know, anybody who's on natalizumab, we're always on at you about what your titers are and all of this. But the reality is that we've been using Tysabri now for 20 years, that we've had 3 cases of PML in New Zealand, 2 of whom were in patients that we would not now have put on treatment because we know that they actually had very high titers, but we didn't know that then. And since we've moved to 6-week infusions, we've had no cases. And I personally think that the risks that we quote you are probably a lot higher than what they actually are because they were all done on the 4-week data. And I think the 6-week data now is actually very reassuring. And there was one study, and again, maybe if I do a talk again, I did a big talk to the New Zealand neurologists a little while ago about PML and the risks. And I think now the risks are much, much lower. But the expectation is that it might be the same as with the other infusions. But interestingly, the breakthrough of disease on ocrelizumab with the injectables, which are done weekly, actually looks better than the infusions. And it might just be, even though the dose is slightly lower, and I think that the feeling is that having that more continuous low-grade activity might be better. And that might be true of subcut natalizumab as well.
So will it still be 6 weekly for subcut?
It will still be 6 weekly. The problem at the moment with Pharmac is that all the trials were done on 4 weekly.
All right.
And the 4 weekly, and we will probably use it 6 weekly. But the problem is, if we use it 4 weekly, the cost goes right up. It's an expensive drug because it's a new indication. And the data is only just coming out that 6 weekly is as effective as 4 weekly, because as you know, there are very few trials about 6 weekly natalizumab. We all just did that because we thought that it was the right thing to do. And it seems that there are a few patients possibly whose levels drop quite a lot. But the general feeling is, and there's one or two studies now that show that 6 weekly doesn't seem to see an increase in relapses or in disease activity on the MRI. The thing about 6 weekly, and I know all of you talk about the crap gap, is that it probably does allow the natalizumab levels to drop a bit. But that's what protects you against PML, because what happens is some of those lymphocytes then actually break out and actually go and do the surveillance that they're designed to do. And it may well be that the fact that you get less PML is just that you've got a little bit more immunosurveillance because the levels are just a little bit. So it's that balance between preventing PML and keeping good immunosurveillance without causing a lot of problems with increasing MRI or disease activity. Yes?
I would like to know more about the peri, is that what you?
Pira.
Pura.
Pira, yeah, P-I-R-A, yeah.
What do you know about it?
So what we know about it is that there are, and we still don't know how many patients, but there are patients who, because perhaps of the way their immune system is set up, that their propensity to neurodegenerative aspect of MS is greater than other people. So you may have heard me talking about the fact that MS kind of has a bit of two faces. The face that we can treat is the systemic lymphocytes that blast out, they cause inflammation, we see it on the MRI scan, and if it's in the right place in the brain, it will cause symptoms for the patient. So that's the acute inflammatory component of MS. But underlying that, there is a neurodegenerative component, which is what we see in secondary progressive MS. So people who are who have got very established MS, who have got no longer experiencing relapses, and if I do their MRI, they're not having any new MRI lesions, but they keep telling me my walking's worse, my balance is worse, my leg is worse, and I believe them. But what that is that progression. And that bit, which we see starkly in primary progressive MS, is what is probably causing PIRA. What we don't know is why does one person get PIRA and another person not? And that is still where the research is.
So they don't even know how to test if you have it.
No, but there is some of the CSF markers that people are talking about is where people are looking. So is there a grumbling sort of, our vision of it is that probably what happens is once MS is established in certain people, it becomes compartmentalized. So the lymphocytes continue to smolder and just zzz away in ways that we can't see. And so what people are doing now is they're looking for biomarkers to look at that underlying bubbling sort of rotorua type, that's going on that we're not seeing. And that's the kind of theory at the moment that might be what it is. And so there are some biomarkers that we're looking at to see whether we can decide who is at risk of that and who's not. Because some people will have MS for 25 years, they'll be on treatment and they'll never develop, never have PIRA. Other people, 2 years on treatment and you're still effectively managing their disease on MRI and clinical grounds, but they're still progressing. So, yeah.
So just to carry on from what you were saying, what about people with primary progressive who've never been given any treatment for it at all? There's nothing available.
Yeah.
Where do we fit in with the PIRA here?
Yeah. So this is where that kind of theory of what is it that causes this progression without obvious inflammatory activity. And we don't have all the answers for that yet. And I think PIRA will be the same sort of thing around primary progressive. As you probably know, there has been recently, PharMac have funded treatment for primary progressive MS using one of the drugs called ocrelizumab. We in Canterbury haven't started infusing people because the DHB has not yet got around to accepting our business case for it. But anyway, I am continuing to work on that. I've been to more committee meetings than I want to in the last few months around this. But and I think again, good on PharMac. Australia have not funded it. England have not funded it. So we are ahead of the world in that sense. And it is a modest treatment, but the feeling is that if there is some grumbling inflammatory type of thing that's going on, then that's the treatment that's going to change it. And so that's the theory behind using ocrelizumab. We know that natalizumab doesn't work. Fingolimod, siponimod, modest treatments. Some of that may be that they just don't get into the CNS, into the brain properly. But yeah, we haven't got that licked yet.
Do we need close to finding cause?
Yeah, that's a good question. So your question is there any sort of, what's the current cause theories? And all of you will have seen years of, oh, it's this, oh, it's that, oh, it's this. One of the things which is quite interesting, and you saw my slides with the kind of lighting up of the autoimmune stuff. So it's always interesting that for most of the autoimmune conditions, we can see that on the lab tests. MS has we've never found what it is that sort of underpins this. And so it's not as simple as some of those other conditions like NMO, spectrum disorder, where we can just see it. And I think that the current excitement, if you like, is around, we come full cycle back to EBV. So there was a paper that was published by a group in America. And what they did is, it was fascinating. As you know, American forces have to have bloods every 3 months, I think it is, or every 6 months for HIV, if they are serving in the military. So they had thousands and thousands and thousands of samples. And what they did is that they got access to those, and I can't quite remember the numbers, but there were about 34 people who had developed MS during their service time. And what they did is that they had all their bloods going back for years. And they looked at infections that they had had over the years. And they particularly focused on those patients who were Epstein-Barr, i.e. glandular fever negative when they went into the military. And every one bar one of those 34 patients that were negative converted at some point before their diagnosis of MS. Whereas when they looked at every other virus that people get, it didn't make any difference at all. So one of the theories, which some people are still very excited about, and certainly the group that I went, when I was in London, I went and spent a day out in the sort of East London with Gavin Giovanoni, and some of you may watch his blog sometimes. He runs a sort of a blog. And Gavin's a big fan of this theory, and he and the group out there are looking at vaccines for Epstein-Barr virus for exactly this reason. But what the theory is that there are a group of people, just because of their immune system, who, because all of us in this room will have Epstein-Barr virus, and not everybody gets MS. And so the theory is that for some patients who get Epstein-Barr virus, something about the way they clear it or something that happens to their immune system sets them up for MS. And so the theory is that if we could prevent Epstein-Barr virus, then we might have some inroads into MS. Epstein-Barr virus causes some very nasty cancers as well, and so there's a lot of initiative for looking at that as well. So, all right. Well, I've probably bored everybody enough now, and so
No, not boring at all. I think we can all agree it was not a glorified holiday. I think you worked very hard on behalf of all the people that you see in Canterbury and in Maida. There were two things that that will stay with me. You said time gives us opportunity, and I think that's true in all parts of our lives. Actually, time gives us opportunity, and probably no more so than this. And then the other thing was, which I know Amin will be very excited by, is exercise is the second best disease-modifying drug. Which segues nicely that if you have not had a free assessment with Amin, please book in, please do so. We're here for that to happen. Doesn't cost anything, it's free, and then from that you can get a the second best disease modifying drug for the pandemic. Thank you very much.